A very good
Okay.
evening to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned internal medicine Dr. N.K. Soni, sir. Sir is MD, FRCP from Glasgow, FSCP, USA, FICP, FIACM, Director Academics and HOD of Internal Medicine at Yatharth Super Speciality Hospital at Greater Noida. With Sir's wonderful insights, we are going to talk about the topic for today, which is sarcopenia and diabetes, double trouble. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you. Please proceed.
Thank you. Thank you very much for your kind introduction, Batul. And welcome to all my friends who have joined this evening for a very important topic to be discussed today. And the topic is none other than how should we manage the health, overall health in a diabetic patients. So actually, from weakness to wellness is the aim, where we'll discuss about discussing the diabetes and sarcopenia connection. We all know that diabetes is a metabolic disorder, chronic metabolic disorder, and with the more advanced medical facilities which are available to the patients, as well as a number of medications, newer insulins, and other measures which can control the diabetes for a long period of time. The patients who are suffering from diabetes, now they are living a longer life. Now, once the duration of diabetes increases, there are many complications which appear in diabetic patients with the passage of time. Whether these are macrovascular complications, which can cause the cardiovascular or cerebrovascular diseases and which can increase the mortality in these patients, and microvascular complication, which can give rise to nephropathy, retinopathy, or neuropathy, which can increase the morbidity in these patients. It affects the quality of life in these patients with the passage of time, with the longer duration of diabetes itself. Not only this, even the musculoskeletal system is also affected to a large extent. And that is what I am going to focus today on, this aspect of musculoskeletal system and the health of muscles in these patients, so that they can have a more productive and good quality of life in their longer duration of the life and disease process. So, to begin with, let us first discuss our agenda. My agenda is about discussing about the relationship between the metabolic disease of diabetes and musculoskeletal health, as we all know that the burden of diabetes is enormous. ICMR has given the data that about 101 million population of diabetic patients is living in our country. It's not only the diabetic population, but even 136 million pre-diabetic patients are also there, which are going to develop diabetes in their near future. So naturally, you can imagine that we are going to have a large population, large number of patients of diabetes in our day-to-day clinic. Now, with the more advanced drugs, more group of anti-diabetic medications, as well as more and more newer insulins which have been introduced, we are able to prolong the life of these patients. Now, with the prolongation, there is a large prevalence of the disease process, even including sarcopenia or muscle weakness, which is very, very evident and which affects very largely the mobility and the quality of life. The risk factors and physiological mechanisms which are involved in causing muscle weakness or sarcopenia and type 2 diabetes I will be discussing, as well as the therapeutic intervention and challenges for the future directions. So this is my flow of discussion tonight, and I think you will enjoy listening to it. And at the end of the day, you will feel that you get some important informations as far as diabetes and sarcopenia is concerned. To begin with, if I start with the definition, the term sarcopenia was introduced in 1988, way back in 1988, and the original definition was a muscle loss of appendicular muscle mass in the older people as measured by DEXA examination. But then this definition of purely muscle loss was considered inadequate. And then in 2010, the definition was altered not only to identify the low muscle mass, but together with low muscle function also, which is very, very important in causing the sarcopenia and affecting the mobility of these patients. And this was agreed upon as reported in a number of consensus papers. So now sarcopenia is considered as not only the decrease in the muscle mass, but even the muscle function of the skeletal muscles. So the sarcopenia, as I told, is the loss of muscle mass, muscle strength, as well as muscle performance. So if it occurs in age-related conditions, that as the patients get elderly, they are not as much active as they were in the younger age, it is called as primary sarcopenia without any comorbid condition or metabolic condition. But if it is associated with any systemic illness, it is caused as secondary sarcopenia, that we should realize and appreciate, and then this needs to be corrected. So the working group of sarcopenia consensus defined that sarcopenia is age-related decline of the skeletal muscle plus low muscle strength and or low physical performance. So we should see that if it is not primary, that is age related, and it is associated with any comorbid condition or metabolic conditions, we'll find that bidirectional relationship is there between musculoskeletal changes as well as metabolic disorders. Like type 2 diabetes. Type 2 diabetes, if you see on the left hand side, it is characterized by insulin resistance, as well as in due course of time, with the prolongation of the period, there is an advanced glycation end products accumulation in the skeletal muscles, where it leads to inflammation and oxidative stress, which can affect after cellular functions of the muscles, affecting the mitochondria and other cellular metabolism, which affects adversely to the cells and thus causes these characteristics which lead to the skeletal muscle loss with the potential causing sarcopenia. On the other side, that is the type 2 diabetes or metabolic disorder which gives rise to sarcopenia. Now let us see if sarcopenia occurs the first. See on the right hand side, sarcopenia actually is the loss of muscle mass and skeletal muscle tissue, which is the primary target tissue for insulin, because insulin acts on the peripheral skeletal muscle tissues and causes glucose uptake, and thus the glucose metabolism is, enhanced, and there is a decrease in the blood sugar level. But sarcopenia, if there is a disease in the muscle mass, the reduction in the muscle mass, it can lead to hyperglycemia because insulin is not able to act over there, and there is an increased insulin resistance where glucose uptake is hampered, and hyperglycemia and decreased metabolic rate, which increases the type 2 diabetes risk in the older population. So it's a bidirectional. If hyperglycemia is there, muscle mass increases. If sarcopenia is there, it leads to the development of hyperglycemia and aggravates the glucose dysglycemia, alters the glucose metabolism and causes hyperglycemia and uncontrolled diabetes in these patients. So naturally, we need to correct both the things, that we should control the glycemia to the targeted level. At the same time, we should see that the muscle strength is also maintained and muscle function is also properly established, and it remains there as a good muscle function, so that the peripheral glucose uptake is maintained in large population. Well, there are many studies in the literature. You can see in this slide that whether it's an original article where the impact of diabetes and sarcopenia is commonly dwelling older adult India is the key finding of the longitudinal aging study, or LASI. I'll come to it later in my slides. Even the prevalence and risk factors of sarcopenia in the patients with diabetes, there was a meta-analysis, as well as there was a review article also in the literature, which says that pathophysiological interactions between the sarcopenia and type 2 diabetes are well established, a two-way street influencing diagnosis and therapeutic options. So there are many chapters and many evidences. These are available in the literature, which link sarcopenia to diabetes, and thus this is a double trouble, which I said in my opening slide. Well, the introduction of unraveling link is also well established. This was the systemic review article in 2021 December, and which said that the association between diabetes and risk of sarcopenia is accumulated evidence from observational studies. So this article also details that there is a definite strong association between diabetes and the risk of sarcopenia, where the patients with diabetes have a significantly higher risk of sarcopenia than the patients without diabetes. So muscle mass is decreased and muscle function is also decreased in diabetic patients, more pronounced when in comparison to non-diabetic population. The relationship between diabetes and risk of sarcopenia was subject to age, with the patient aged less than 60 years and having a higher risk in diabetic patients than those aged more than 60 years but without diabetes. So if we compare a diabetic patients who are non-diabetic patients, even less than 60 years of age, they develop sarcopenia, while even more than 60 years of age without diabetes, they do not have that much of muscle loss or muscle functions dysfunction. So the association between HbA1c and the risk of sarcopenia is very strong, where it says, this review article, that HbA1c level, muscle mass, and performance were negatively related to the patients in type 2 diabetes, more evident with HbA1c level when it was more than 8.5%. So higher the HbA1c, lower is the muscle mass, lower is the performance. So that is a negative association or reverse association between HbA1c level and sarcopenia. Even the pre-diabetics, the risk of sarcopenia is there. The subjects with pre-diabetes present lower muscle mass, lower strength, and performance than non-diabetic patients as such. So the dual burden of diabetes and sarcopenia was observed in this study from China, where the prevalence and risk factors for sarcopenia were observed in the patients with diabetes. It was a meta-analysis. And what was the results of this meta-analysis? That the pooled prevalence of sarcopenia among diabetic patients was found to be around 18% in this Chinese population, where men with diabetes exhibit a higher prevalence of sarcopenia at around 20%, while female compared to 17%, it was observation was done in females in comparison to males. So male preponderance was observed with sarcopenia in diabetic patients. Asians were found to be more prone to develop sarcopenia in comparison to South America or Oceania population. So we all know that metabolic disease is more pronounced, more severe, occurs early, causes more damage, more pronounced microvascular and macrovascular complications in Asian populations. Same way, even sarcopenia is also more pronounced in Asian population, it was observed. And it was also observed in this meta-analysis that 18% prevalence in hospitalized patients of sarcopenia and 15% was observed in community. So once the patient is hospitalized, the muscle loss or sarcopenia gets aggravated and it becomes more pronounced. And this was the findings of this study. And the longitudinal aging study in India, that is LASI study, also observed this sarcopenia and diabetes association in Indian older adults. And this was the LASI study. And you will find here that if diabetic population in India is around having about 11.7% prevalence, the sarcopenia is prevalent in around 23.5%, while in other studies, Caucasians and Oceania patients, it was around 18%, but in Asian population is a little more with around 23%. And if we observe both sarcopenia and diabetes, that is quite common. And if we see the percentage, if around 3.4% or 4%, but if we assess the number, that if 101 million population, if it is suffering from that, and then you convert it into the number, you will observe that the number will be quite high. So this study, LASI study or longitudinal aging study in India, observed that the study assessed the association between sarcopenia and diabetes in over 27,000 community dwelling older adults in India from the community-based study. The participants with diabetes had a significantly higher odd ratio of 1.14 for sarcopenia, while diabetes was more prevalent in men. Older women faced a higher risk of developing sarcopenia due to hormonal changes. Menopause also causes the muscle weakness and muscle functions loss. So that aggravates the problem in the older ladies, where the incidence of sarcopenia is higher in a diabetic females. The study on pre-sarcopenia in Asian Indian individuals found a higher prevalence in those with type 2 diabetes, and ultimately this study observed that in India, addressing the diabetes through diagnosis and monitoring is crucial for prevention of serious complications like sarcopenia. So it's not only the macrovascular or microvascular complication, but skeletal muscle disorders or sarcopenia is also a very important complication which should be observed with the meticulous control through the diagnosis and monitoring of glycemic level in diabetic population in our country. That is the conclusion of this study. Well, if I discuss about pre-sarcopenia, that pre-sarcopenia in Asian Indians with and without diabetes, this study where the participants with type 2 diabetics were about 76 in number and age and sex match control without diabetes were about 76, were drawn from Chennai. And this study representing the sample of Chennai city in South India, it also, I'm sorry. Oh, I have to go back. Oh, how should I do that? Virtual background. Oh, yes. So this study also revealed that if we see on the horizontal bar that as the blood sugar level, fasting plasma glucose level increases, the chance, the prevalence of pre-sarcopenia also increases tremendously. Higher the fasting blood sugar, higher is the pre-sarcopenia. And these patients, once they develop higher blood sugar level and frank diabetes, sarcopenia also sets in. Same is with the glycated hemoglobin or HbA1c. Higher the HbA1c, more are the chances of sarcopenia in these patients. So even the pre-sarcopenia, in comparison to the patients, elderly patients who are not having diabetes, it was found that those patients who are having diabetes, even the pre-sarcopenia was very common. And this was the study from India, from Chennai. So there is an interesting risk element in the onset of sarcopenia and type 2 diabetes. You will see that as the age advances, the sarcopenia sets in or muscle weakness sets in. The body mass index, if it goes up, even with the fat deposition, or if it goes down with the fat deposition, the sarcopenia sets in. Diabetes duration, also longer the duration, of course, sarcopenia appears. Similarly, with glycemic control, if it is poor, more severe is the sarcopenia. Same way, microvascular and macrovascular complications, which appear because of dysglycemia in the long term, it sets in the muscle dysfunction, skeletal muscle dysfunction in the large population. And same is with the nutritional status and lifestyle, that if nutritional part is poor with hypovitaminosis, the sarcopenia sets in. So these are the factors which affect, these are the risk elements which affects the onset of sarcopenia in type 2 diabetic patients: age, BMI, diabetic duration, glycemic control, the complications of macrovascular or microvascular, as well as nutritional status. So these are very important. Let me discuss these aspects one by one. So let us start with age, and you will see that individuals with type 2 diabetes and sarcopenia are older, with an average age of around 70 plus, and approximately 40% of type 2 diabetic patients, which are aged more than 80 years or older, have severe sarcopenia, which was observed in large population. The prevalence of sarcopenia, thus the conclusion was that the prevalence of sarcopenia in type 2 diabetic patients increases progressively with age. As far as BMI or body mass index is concerned, sarcopenia prevalence decreases as BMI increases. So, stronger is the metabolism, stronger are the muscles. Decreased BMI and increased body fat are associated with sarcopenia in type 2 diabetic patients with lowest prevalence in third quartile of the body fat. As far as the diabetic duration is concerned, longer duration is linked to higher sarcopenia prevalence, found prevalence rate which increases with the age, advancing age. Then glycemic control. It was observed by Sugimoto et al. That association in lean individuals is the glycemic control is independent of other major covariates. So, glycemic control, if it is good, the muscles are strong. If it is poor, the poor glycemic control or hyperglycemia causes more muscle loss. The microvascular and macrovascular complications, there were many studies, Japanese study, Fukuda et al., Bochi et al., They all observed that sarcopenia associated with diabetic retinopathy, especially proliferative retinopathy. So microvascular complications gives rise to more sarcopenia. Similarly, Bauchi et al. Also reported that the presence of sarcopenia increased the risk of progression of albuminuria. So if nephropathy sets in, it also causes more sarcopenia. Neuropathy was more frequent in sarcopenic group, especially among women. So these are the 6 very important factors, variables, which cause the development of sarcopenia in diabetic patients, and we should always keep it in mind. So there is a silent nexus with a shared pathophysiology, right from is starting with insulin resistance, which causes the release of pro-inflammatory substances causing inflammation, oxidative stress, the deposition in the muscles of advanced glycation end products, even intramuscular adipose tissues or IMAT, and the disturbance in gut microbiota, which is again an overlooked factor and which can give rise to sarcopenia in type 2 diabetic patients. So all these factors, they interact with each other and causes sarcopenia in diabetic patients. A word about insulin resistance in sarcopenia and type 2 diabetes. We all know that insulin resistance is the first pathophysiology which starts in diabetic patients in Asian populations, and Asian Indians are more prone to develop this insulin resistance early in the course of their life. So, diabetes involving insulin resistance causes the inhibition of protein synthesis pathways with the reduced muscle mass, and it causes the release of inflammatory cytokines, reactive oxygen species, myostatin, and calpain. These are all inflammatory markers which are associated with diabetes also and cause inhibition in protein synthesis with the increased protein catabolism as well as reduced muscle mass, thus lead to development of sarcopenia. Hyperglycemia thus contributes to decreased WWP1 levels, again inflammatory markers which can increase the KLF15, which is again exacerbates the protein catabolic pathway, ultimately causes the muscle atrophy. So these are some of the cellular mechanisms and the release of pro-inflammatory chemical substances which occur with insulin resistance and hyperglycemia, and thus form a very definite correlation between type 2 diabetes as well as the sarcopenia, which coexist and affects the quality of life of these patients. So the impact of inflammation on the muscle health in type 2 diabetes at the cellular level, which affects the protein metabolism. Inflammation reduces muscle protein synthesis, whereas it increases the protein breakdown as well. Also, it increases the pro-inflammatory factors, especially IL-6 and TNF-alpha, as well as it causes a negative feedback and signaling pathway, thus increasing the breakdown of the muscle proteins and causing the muscle weakness. So the interleukin and muscle atrophy are very significantly correlated with each other. The inflammatory cascade, which is initiated by TNF alpha and interleukin 1, it leads to muscle atrophy and causing more of sarcopenia in diabetic patients. So, sarcopenia in type 2 diabetic patients, there is a definite role of oxidative stress and inflammatory markers, where oxidative stress contributes to aging and disease, and type 2 diabetes is linked to increased oxidative stress with increased ROS production or reactive oxygen species. Reactive oxygen species activation causes muscle protein degradation, handing the muscle strength and causing sarcopenia, and thus mitochondrial dysfunction, which is driven by oxidative stress and worsens the health and increases the sarcopenic risk as well as the weakness and morbidity in these type 2 diabetic patients where sarcopenia sets in. So, what is the role of advanced glycation end products, which I was discussing earlier, as well as intramuscular adipose tissues, which are deposited because of lipolysis and disturbed uh, fat metabolism, which occurs in diabetic patients. As far as advanced glycation and products are concerned, type 2 diabetic patients have got the chronic advanced glycation and products accumulation, which is associated with insulin resistance. AGE is accumulation in neuromuscular tissues affecting their biochemical properties, and it increases the oxidative stress via RAGE receptors as well as elevate the skin. Advanced glycation end products correlates with the higher prevalence of sarcopenia, and the muscle functions are decreased in these patients. Similarly, intramuscular adipose tissue or IMAT, diabetes related obesity can lead to fat accumulation in the skeletal muscles, which again causes insulin resistance, and the glucose uptake in the skeletal muscle is decreased, thus causing aggravating hyperglycemia. The fat accumulation in the muscles gives the insulin signaling and mitochondrial dysfunction, causing muscle atrophy. And with the increased ROS production, that again causes membrane stiffness as well as muscle degeneration. So, inflammation of fat into the muscle affects the skeletal muscle elasticity and causes the symptoms of sarcopenia to occur in these patients. This is a histopathological diagram where it shows that in a lean and healthy individual has got more of a muscle mass with a thin ring of fat, but in a sarcopenic obese patients, the fat ring is becomes thickened, and the muscle mass, the skeletal muscle mass, is decreased, and thus the symptoms of sarcopenia or muscle weakness occurs in these patients. A word about gut microbiota link. Well, the dysbiosis of gut microbiota plays a crucial role in the development of insulin resistance and type 2 diabetes, where it causes increased intestinal permeability with a low grade endotoxemia, with the alteration in short chain fatty acids as well as branch chain amino acids and gut hormone secretions. So, all these abnormalities which occur because of the disturbance in gut microbiota, the patients with type 2 diabetes and pre-diabetes exhibit changes in the composition and function of their gut microbiota. And thus, the gut microbiota is a significant contributor to the pathogenesis of both sarcopenia as well as diabetes. So this is a very good diagram to show that sarcopenia and diabetes, they are two sides of the same coin. So if you observe here, the skeletal muscles where the insulin resistance sets in with the decrease in the beta cell activity, beta cell failure, with the decrease in the beta cell activity, increased plasma insulin concentration, because body wants to compensate with hyperglycemia. There is a decrease in the skeletal muscle insulin sensitivity, which aggravates to the problem of hyperglycemia. Beta cell failure leads to diabetes with the insulin deficiency, which has the catabolic effects leading to sarcopenia again. And it also causes the increase in the plasma free fatty acid because of the dysfunctional lipolysis, increased inflammatory cytokines, decreased fat oxidation, as well as decrease in the mitochondrial oxidative capacity. At the same time, it also causes a decreased daily protein intake, decreased physical activity and exercise, which again further aggravates the problem of sarcopenia in these patients. So, in fact, sarcopenia and diabetes are two sides of the same coin, where the whole pathophysiology starts with the insulin resistance and causing hyperglycemia, the dysfunction of the beta cells, as well as muscle weakness and muscle functions. So, once we know this pathophysiology, We assess what is the definition of sarcopenia by European Working Group in older people. It sets the criteria where we have to assess the patients with the low muscle strength. Low muscle strength of a patient is assessed by various methods, clinical methods, practical methods, like grip strength, where you can ask the patient to grip your hand and you can assess how much powerful is the grip, as well as chair standing, where we ask the patient to stand and sit on the chair at least 5 times within 15 seconds. If the patient is able to do it, we assess that the muscle functions are good. If the patient is not able to mm, at least rise 5 times from the chair, from the sitting from the chair within 5 seconds, within 15 seconds, there is an assessment. The diagnosis is probably the patient is having sarcopenia. So these are two very practical methods. If we want to assess the low muscle quantity or quality, then we have to see the appendicular skeletal muscle mass, and that is assessed by various methods which are available on Google also, where we assess that if it is deficient in skeletal muscle mass, appendicular skeletal muscle mass, or ASM, there is a probably diagnosis of sarcopenia is established. For severe sarcopenia, we see the low muscle performance. This is the low muscle strength for probability. This is the low muscle quantity and quality. And then the low muscle performance, the gait speed, the short physical performance, or even we ask the patient to walk for 400 meters, where non-completion of this 400-meter test for more than 6 minutes for the completion, that leads to the diagnosis of severe sarcopenia. So these are the tests to assess the, the muscle strength, quality or quantity, as well as muscle performance, and where we can assess the whether the patient is establish the diagnosis, whether the patient is having sarcopenia or severe sarcopenia if he is not able to walk for 400 meters within 6 minutes or so. So how should we approach to a patient of sarcopenia? First, we should do the screening. For the screening, we should assess the BMI or waist circumference based on the ethnic cut points, and surrogate parameters for sarcopenia like clinical symptoms, the grip method, or the chair standing method, the clinical suspicion, or even questionnaires. So both conditions must be present to proceed with the diagnosis of sarcopenia: BMI, waist circumference, as well as the clinical symptoms. The next step, we go for the diagnosis. The diagnosis is confirmed on two steps. One is the altered skeletal muscle function parameters, like again strength, chair standing test, as well as muscle functional parameters such as the presence of sarcopenic obesity on the diagnostic process, which will continue considering body composition. The second step for the establishing the diagnosis is altered body composition with the increased fat mass in the muscles, fat muscles, with the reduced muscle mass and increased fat composition, which can be done with DEXA and other methods. Both altered body composition and altered skeletal muscle functional parameters should be present to assess the presence of sarcopenic obesity, and that establishes the diagnosis of sarcopenia. So altered muscle function as well as altered body composition, these are the two steps to establish the diagnosis. Now if we then we go for staging. The staging is that that it should be performed at two levels, resulting from high fat mass and low appendicular skeletal mass to better mirror progressive severity of sarcopenic obesity. So, stage 1 of sarcopenic obesity is when it is not associated with any complication, it is only age related of primary sarcopenia. Stage 2 is the presence of at least one complication attributable to sarcopenic obesity, like metabolic disease, like diabetes and others, functional disabilities, cardiovascular and respiratory diseases. So, if comorbidities are associated, then we level it at stage 2. So, this is how we approach a case of sarcopenia. Now, we go for management. For management, it's a first a non-pharmacological management. We should evaluate the and detection of the deterioration of physical functions and activity of daily life in older adults we should do, and we must be actively performed by health professionals. The main non-pharmacological measures are very, very important as far as the management of sarcopenia are concerned. Physical activity, nutritional counseling, improving the mental health, cognitive stimulation, avoiding the hypoglycemia and good control of glycemia, neither hyperglycemia, where it should be good controlled, but nor causing hypoglycemia, even fostering the social ties that patient should not be left alone. The mental, disturbance also and loneliness also causes muscle weakness, and fall prevention is very, very important in the elderly population. So the main management of sarcopenia is physical exercise in combination with nutritional intervention, whether both aerobic and resistance exercise, which can prevent and treat the decline in the muscle mass. Glucose level should be monitored. Warm up approximately 5 minute and 3 minute cool down is recommended. Energy intake of about 30 kilocalories per kilogram body weight per day, with the protein intake of 1 to 1.2 gram per kg body weight per day is recommended. Vitamin D helps in improving the muscle mass and strength, and as well as Mediterranean diet is highly recommended with high protein and low carb and more fiber in the diet itself. Well, lifestyle recommendations. This is a pictorial presentation where more than 2 resistance training per week, more than 150 minutes of walk per week, and sedentary behavior should be less than 8 hours per day, with protein intake should be good, as well as the other vitamins and minerals, omega 3, creatine, vitamin D, etc., should be supplemented. And even the HbA1c should be well controlled from 6 to 8 if there is a progression of type 2 diabetes, progression of hyperglycemia, there is a progression of sarcopenia as well. So we must observe all these parameters in these patients for a good, healthy lifestyle. Exercise as medicine, the tailoring the physical activity for diabetic sarcopenia. The clinical practice guideline emphasizes physical exercise as the primary treatment for sarcopenia. That should always be kept in mind, that physical exercise is the primary treatment of sarcopenia. Whether we ask the patient to do aerobic exercises, which improves the skeletal muscle mass, especially leg strength, and reduces the HbA1c, or resistance exercises which enhances the muscle strength, or short-term moderate intensity resistance exercise, or blood flow restriction training programs. These are all available which can be chosen for strengthening the muscle mass or muscle functions altogether as such. As far as the nutritional intervention is concerned, after the exercise, this fuels the fight against the muscle wasting. Protein intake, even the elderly population, they need increase proteins to 1.2 to 1.6 gram per kg body weight per day, and higher protein intake has been linked to decreased muscle mass. Protein from plant sources could be beneficial for women and older adults at risk. That is very, very important. Vitamin D receptors in the pancreas and skeletal muscles imply its role in glucose and muscle homeostasis, and its supplementation can increase the muscle strength in those with vitamin D deficiency. And we all know that majority of the population, we find vitamin D deficient in our day-to-day clinical practice. Combining vitamin D supplementation with exercise can boost the muscle strength. Even omega-3 supplementation can increase the muscle protein synthesis and decrease the systemic inflammation. Omega-3 supplementation may have potential as an adjunct therapy during the exercise also. So exercise with the supplementation of these nutritional aspects, nutritional points, it helps in strengthening the muscles, their strength as well as the muscle functions. The pharmacological frontiers, medication and muscle health. We should always remember that no approved drug for sarcopenia therapy is currently available. Hormonal intervention, whether it is a testosterone gels or selective androgen receptor modulators, SARMs, are potential targets. Lifestyle modification expected to remain the primary treatment for type 2 diabetes and sarcopenia, we should always remember. As far as the transdermal testosterone gels are concerned, it increases the blood androgen concentration, benefiting the skeletal muscles, but have got limited side effects as well, where it causes dyslipidemia, benign prostatic hypertrophy, uterine hyperproliferation. So it should be used with caution under medical supervision. Same way, selective androgen receptor modulators have got a positive effect on body composition and function in clinical trials, but have got side effects like hepatotoxicity and off-target effects on genitalia also. So these are also, all these drugs should be used with caution under medical supervision, but lifestyle modification is the primary aim, primary target to improve the health of skeletal muscles. There are some anti-diabetic drugs also in type 2 diabetic patients which affect the muscle health. Metformin can, of course, be used safely where it has got the positive effect on the muscle mass, but sulfonylurea and glenites, these are to be used with caution, as it should be avoided in the patient with sarcopenia, and these cause little more muscle weakness. Although DP4 inhibitors, GLP-1 receptor agonists, they are little safe. SGLT2 inhibitors also, because of the sometimes electrolyte imbalance causes, are to be used with caution in elderly population where the chances of genitourinary infections are increased more. The insulin has also got the effect on the muscle health, but the effect on the muscle health is not well established, although it causes good control of glycemia. But of course, its androgenic effect can help in the muscle strength, although it's not well established. So we should use all these drugs with caution in these patients once we are using in type 2 diabetic patients as such. So, my dear friends, there is a diagnostic dilemma and the challenges in identifying sarcopenia and diabetes. The challenges in sarcopenia screening is with a limited knowledge on sarcopenia definition as well as the diagnostic algorithm among the primary care physicians. Challenges arise in selecting appropriate screening tools. Challenges in sarcopenic diagnosis are also there with the high cost of diagnostic tools like DEXA with the limit availability in the primary care, as well as bioimpedance analysis may be overestimated muscle mass but is suitable for adjacent equations. So the recommendations are that primary care physician should initiate screening for sarcopenia and refer for diagnosis and treatment. Use validated software to complement the traditional method. Identify modifiable risk factors and consider diagnostic tools practicality and maintenance, as well as implement cost-effective technology for improving the diagnosis. So there are challenges, but we should always keep in mind that if we want to provide a good quality of life to our patients, we should deal with sarcopenia also in the early course of the disease as such. What are the future horizons? What lies ahead in the research? That is very important for us to know, that future directions offer potential avenues for the development, like mitochondrial targeted antioxidants. It addresses the oxidative dysfunction. All the future targets are at the cellular level to improve. Even myostatin inhibition, potent negative muscle growth regulator, they reduce myostatin expression and increases the muscle mass, as well as endothelin 1 pathways, which plays a very crucial role in mediating the myopathy and adipose inflammation. So these are the future horizons where the work is going on, and in the coming years probably we'll be having little more targeted therapy at the cellular metabolism, correction of the cellular metabolism, and increasing the muscle strength. So, my dear friends, I would like to summarize over here with my last slide that sarcopenia is closely associated with type 2 diabetes, and the two conditions often coexist. Risk factors contributing to the onset of sarcopenia and type 2 diabetes include aging, which is very important aspect with the advanced medical services or medical therapies which are available in type 2 diabetic patients, physical inactivity, poor nutrition, obesity, as well as insulin resistance. These are all very important factors which aggravate hyperglycemia and even causes sarcopenia. Pathophysiological mechanism like sarcopenia and type 2 diabetes involves complex interaction related to muscle mass, insulin sensitivity and inflammation, as well as mitochondrial dysfunction at the cellular level with the release of pro-inflammatory substances. Therapeutic intervention encompasses lifestyle modification, exercise, as well as dietary changes. Identifying sarcopenia in individual with diabetes can be challenging. Recommendations include using validated tools and technologies to enhance diagnostic capabilities, which is uh, relatively scarce, but even the idea, even the concept, even the sensitivity of sarcopenia should be there in the mind of clinicians once type 2 diabetic patients come to their clinic. Emphasizing the well being of the older individuals, timely identification of sarcopenia is crucial for efficient management as well as particularly in the individual with diabetes. And thus, if we are able to do that, at least we'll be providing more service, better service to our type 2 diabetic patients, where we can provide them with a good quality of life. Now, with this, I would like to end my talk and would like to thank all of you for your patient listening. Thank you very much.
Thank you so much, sir. Thank you for such an overwhelming talk that you have shared on our platform and for making our viewers understand about the topic in such a better manner and for letting them understand about it. Moving ahead with the question answers round, sir, we have received few questions, and the question is related to the early signs. So, what are the early signs and symptoms of sarcopenia in diabetic patients, and how do these differ from non-diabetic individuals with sarcopenia?
Well, many studies have shown that the sarcopenia or hyperglycemia, because it all starts with insulin resistance, it also causes the muscle weakness. The first signs of sarcopenia, which practically we can observe in our patients in our day-to-day clinic, is by their walk. Once they walk, whether they walk briskly or they walk slowly, whether there is a breathlessness while they are walking in our clinic, or we can also assess very clearly with the grip that the patients, you can shake hand with the patient, and you can observe the grip of the patient, that whether it is weak or it is strong enough. So these are the criteria where in elderly population or in the population with comorbidities of metabolic disorders we should always assess. And these are the first steps to diagnose that probably these patients are having little muscle weakness, which should also be evaluated further.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question, and the question is related to the complications. So, how does sarcopenia complicate the management of diabetes, particularly in relation to glycemic control, insulin resistance, and the risk of hypoglycemia?
So we all know that diabetes is a metabolic disorder which persists with the patient lifelong. And the lifestyle modification is a primary prerequisite for managing a good glycemic control. That includes the physical activity as well as diet control. So, physical activity is very much correlated with muscle strength and muscle weakness and muscle function. So, sarcopenia, if it sets in early, the physical activity of the patients is hampered, and with the hampering of the physical activity, the glucose control is also gets disturbed and further aggravates the problem of hyperglycemia. This is the clinical aspects. As far as the cellular level is concerned, with the cellular level, we see that the patients, they in the patients there is a release of pro-inflammatory markers. With the pro-inflammatory markers, there is again the uptake of glucose is hampered, and with the hampering of glucose uptake at the skeletal muscles, further insulin resistance sets in and causes hyperglycemia in these patients. So this is how it's a complex vicious cycle where once the sarcopenia sets in, hyperglycemia the glucose metabolism is disturbed, the blood sugar level goes up. Once the blood sugar level goes up, it causes more insulin resistance, more dysfunction and weakness of the muscles, and causing more sarcopenia. So it's a vicious cycle where both the things, good glycemic control as well as physical activities, are essential.
Thank you so much, sir. Thank you for answering that question. And for the other question as well, I hope that our viewers who have put across their questions, they must have got the answer that they were searching for. And with this, I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us and such valuable feedbacks. And I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights along with the PPT that you have made us watch. So thank you so much for that, sir. And before concluding, sir, any last take-home message from your end?
I would also like to thank all my colleagues who have joined this evening for this interactive session, as well as I would also like to thank MedTalks IGCP for giving me the platform for for discussion of this topic, very important topic, which affects large number of patients in our day-to-day clinic. My take on this concluding remark is that whenever the clinician should see the type 2 diabetic patient, they should not only concentrate on the on controlling the blood sugar level, but the holistic approach should be adopted, where good control of glycemia, good control of blood pressure, lifestyle modification, increased physical activity, diet control, everything is very, very important for having a good quality of life in type 2 diabetic patients. So they should always keep in mind that sarcopenia is also very important aspect where they should observe for their type 2 diabetic patients.
Right, we said, sir. Thank you so much for such valuable
Thank you.
concluding remarks from your end. And with this, we would like to conclude the session here for today. Until next time. Thank you, sir.
Thank you very much. Thank you. Namaskar.